cap off what has been an extraordinary day filled with research, collaboration, and discussion, much discussion. We bring in a bit of a fan favorite who always brings us back to the basics, which is fantastic. He has published approximately 400 papers in the field. He is a PhD from Johns Hopkins. Please welcome Dr. Arnold Caplan.
I'm going to talk about MSCs, and I'm going to tell you and plead with you and beg you and exhort you to not call them stem cells. I know that is going to rub lots of people the wrong way, but I've been doing that my whole life, so that's okay. So this is my disclosure information. I started a company called Osiris Therapeutics. I don't have any association with that company. The university gets a royalty from them, and they share that with me. It won't buy peanuts for this crowd. I'm also not listed a consultant for lipogens. You'll see why that's important. So this was a slide that I generated in the late 1980s. This slide was completely rejected by my esteemed colleagues because in the late 1980s it was well known, that means dogma of the day, that there was only one stem cell in adults, and that's the hematopoietic stem cell. And so when I proposed that in bone marrow there was another stem cell, which I called a mesenchymal stem cell, and it could be induced to form bone or cartilage or muscle or marrow or fat, there was not a broad acceptance of that idea. And I can tell you for fact that we've proved every one of those lineages in tissue culture, and I can make cells dance on a petri dish like you've never seen before. So they twitch, they wave at you, they do all those wonderful things, and that's on a tissue culture plate. So I'm going to skip to the end of the talk and tell you what the current Caplan dogma is, which is that these MSCs are derived from perivascular cells that are called pericytes. And what you see is a capillary in heart, and my good friend Bruno Piot colored the perivascular cells red, and you can see they have these tentacles around that blood vessel. This is the vasoresponsive element of every single blood vessel in your body. So when Steve Sampson got up this morning and took his blood pressure medication, this is the cell that responded. So when you want high blood pressure, it squeezes the vessel. When you want low blood pressure, it relaxes. And what I'm going to show you is, and again, every blood vessel, there's no artery, vein, whatever you want, they're all pericytes. So what you see in these scanning EMs, every one of those cells on the outside of the vessel is a pericyte. Every one of the cells that you see on the outside of these vessels is a pericyte. Every one of these cells on the outside of these vessels is a pericyte. Every one of the cells that you see on the outsides of the vessels is a pericyte. It gets boring. Every blood vessel, every single blood vessel, without exception, has mesenchymal perivascular cells. Some of those pericytes can differentiate into an MSC, and I'll show you that in a minute. So every tissue of your body, I can take every tissue of your body and I can isolate these perivascular cells, these MSCs, and in tissue culture, of course, I can make them dance. I can make them become bone or cartilage or whatever you want. What's missing from this slide was that we forgot that every one of those tissues has vasculature. And that's where the MSCs are coming from. So we know how to rip the MSCs off the blood vessels and put them on a petri dish and get them to dance in culture, cartilage, bone, fat, whatever you want. But that's on tissue culture. So MSCs are multipotent cells in vitro. That's not what they do in vivo. What happens in vivo is the following. You break a blood vessel. Now everybody look at me instead of the slide. Blood vessel. Here's a pericyte. You break the blood vessel, the pericyte comes off and it differentiates into an MSC. From the front of the MSC, it produces a curtain of molecules that stop your overaggressive immune system from surveying the damaged tissue. That's your first line of defense against autoimmune reactions. From the back of the cell, they produce molecules which help that tissue regenerate itself. So the dogma that all of your tissues do not have stem cells except for your blood is completely wrong. So Samson last night, when he had all that red wine, he knew that all those neurons that he was killing with that red wine, that he was going to regenerate them because he has neural stem cells. He has liver stem cells, cardiac stem cells, kidney stem cells. Every time you wash, you're washing off dead cells. There's stem cells that are producing those keratinocytes that are dropping dead, that are giving you that barrier function. So every cell in your body, every tissue in your body has its intrinsic stem cells. The MSC that comes from the broken or inflamed blood vessel actually manages the tissue intrinsic stem cells. So your job as a physician is to manage the regenerative capabilities of the patients, and the MSC is a vehicle for doing that. And that's its in vivo function. Regardless of how I can make those cells dance on a petri dish, what they do in vivo is what I just described. And that's what I missed in the initial studies 20 years ago. And now, clinical trials, you go to clinicaltrials.gov and you put in mesenchymal stem cells in their search engine, 615 clinical trials now listed on that website using MSCs. Very few of those are in orthopedics, and here are all the clinical symptoms that are in those things. And if you can't read it because you're too old, I put it in bigger type. So look at these clinical symptoms: Crohn's disease, graft versus host disease, MS, ALS, kidney transplant. There's a 2010 JAMA paper by Dr. Tan and his associates where they transplanted 159 kidneys into recipients, immunosuppressed a third of them, IL-2 immunosuppression, light IL-2 immunosuppression for a third, and the last, as that group's going to have problems, and the last third, light IL-2 immunosuppression and autologous marrow-derived culture-expanded MSCs. Those patients, no infections, all takes. 1 year later, fabulous kidney function from all of those patients. And now Tan and his colleagues are doing a clinical trial just using MSCs as chaperones for kidney transplantation, no immunosuppression. So that curtain, so Steve's cells, if I injected them into my bloodstream, okay, of course I would tingle with the thrill of having his cells in me, okay, but as a matter of fact, my immune system, because of his curtain, my immune system would not immediately recognize them. So they could go to the places where there's problems and do their dance. Acute myocardial infarct, chronic heart failure, rheumatoid arthritis, lupus. What do all of those have in common? Immunomodulatory and trophic effects, regenerative effects, and the other mind blower is antibiotic effects. So everything I just talked about, every single thing I just talked about has nothing whatsoever to do with STEM anything. So because I have an enormously delicate ego, and you have to be sensitive to that as an audience, I want you to keep calling them MSCs. So I've renamed them medicinal signaling cells. These are drugstores for sites of injury for managing the regenerative capabilities of that tissue. So there are 20, 30 companies in this space. I'm going to talk about one. At the moment, lipogyms, because of all of this talk about adipose tissue. And remember, the Caplan mantra is an MSC, is an MSC, is an MSC. comes from fat, comes from brain, comes from skin, comes from heart, comes from marrow. MSCs all do the same things in vivo. They all have different chemistries on their cell surfaces because they're coming from different tissues. So the fat from my butt and the fat from my ear, those MSCs are going to do the same things, but they'll have slightly different chemistries. They've come from different sites and different embryonic origins. So Lipogens has this apparatus which is filled with saline, and you put a liposuction material into this, into the port end on the left side, and there's a grid, a stainless steel grid which further disperses this. And then this was invented by a wonderful guy, Carlo Tremolato, who's a plastic surgeon in Milan. And in this little apparatus are stainless steel balls, a Fibonacci number of balls, because he's Italian and he believes in that kind of stuff. And you take this now with this liposuction in there, and you do the martini shake, okay? And you're mechanically ripping the cells off the blood vessels. You then put saline in, you wash out all the broken cells, you wash out all of the fat and the bits and pieces, and what collects at the bottom end, because there's 500 micron holes at the bottom end, are wads of adipocytes with MSCs inside. I can't think of anything more perfect to put into a joint. Put a couple of mLs of this stuff into a joint, the acute inflammatory response causes huge amounts of liquid to come through that joint, and meanwhile, this protective environment protects the MSCs. 3 to 5 days later, the MSCs walk out and do their thing. This is what the ball looks like with live adipocytes. And the reason I know the MSCs come out, because in my lab and in other labs, we put these clusters in culture. And of course, they're adipocytes. They're filled with fat, so they never sit down on the bottom of the plate. And 3 to 5 days later, you see MSCs walk out. And of course, I think I can recognize an MSC when I see one, but we've done all of the appropriate tests to prove they were MSCs. So this is Rodrigo Somoza, who been in my lab for several years. He's from Chile. And Rodrigo sat down one day at the request of a company, wanted, through Nature Protocols, wanted us to make a poster. And we put together this poster, and here's the website. You should really go to that website. You can download this poster, because this poster has all of the most recent information associated with MSCs, and some of it is mind-boggling, because we finally sat down in a room, 4 or 5 of us, and put this story together. So let me just cherry pick some of the interesting pieces from this poster. The most interesting piece on the whole poster is this simple small panel. And that says that every one of those stem cells that is specific to a tissue, they're all sitting in the same kind of universal niche. And that niche is the stem cell is sitting next to a perivascular cell, MSC. Read that as MSC. And both of those cells are in contact with a vascular endothelial cells. This is exactly the case in liver, exactly the case in brain, exactly the case in heart. Every one of those tissue-specific stem cells, including the hemopoietic stem cell, is sitting in contact with an MSC. So on the right side of this slide is actually a picture from another group that's been completely ignored, 2012. And again, the mantra here is the blue pericyte is sitting in contact with a vascular endothelial cell and a neural stem cell. So, and there are some things that you learned as physicians in medical school. So there's another thing I'm going to tell you which is completely wrong. So you were taught that the vascular system is hooked up to the sympathetic nervous system. That's in every textbook I've ever seen, okay, forever. That's completely wrong. The cell which is innervated is, of course, the perivascular cell, the pericyte, because that's the cell that can squeeze the blood vessel. So it's the responding element of the sympathetic nervous system, not an endothelial cell. You hook up an endothelial cell with a sympathetic neuron, it does nothing. So that's number one. Number two is, on this panel, we've indicated that there is a hemopoietic stem cell which is active, making its cellular products, and there's a hemopoietic stem cell which is quiescent. So the MSC pericyte that's sitting next to it is making different molecules for those two different cells, and indeed, it has a different cell surface architecture, it has a different signature. So we can sort those two different kinds of MSCs from marrow and show that one was sitting next to a quiescent hemopoietic stem cell and one was sitting next to an active hemopoietic stem cell. So again, I don't have time to go through this because the red light is beeping, but we've been studying how melanoma gets into bone. And the dogma in the cancer field is melanoma eats its way into bone and marrow. That also is completely wrong. What happens is that pericyte, remember those pictures I showed you of vessels completely covered with pericytes. How is a melanoma going to get through all of those pericytes? So it turns out that the pericyte MSC sticks its fingers through the sinusoidal vasculature. It grabs the melanoma and it contracts and pulls the melanoma into the marrow. We know the molecules involved. So the marker for pericytes that's been published in 50 papers is CD146. So I'm going to tell you I'm going to ruin your day, and I'm going to tell you the name of that protein. It's called melanoma binding protein. And that's the protein that makes contact with the melanoma and helps pull it into the marrow. So that's another whole story. There's a published paper on that. So again, go look at this poster. This is as best as we can do today. It's going to change, I'm sure, the science of MSCs as is related to this area. So MSCs are drugstores. They're not stem cells. We know the molecules that bind the MSC to the basement membrane of every one of these blood vessels. The key molecule is PDGFBB. Let's see, is that what's in PRP? PRP contains gigantic quantities of PDGFBB, this boring molecule. This molecule is what is exactly anchors that pericyte to that blood vessel. We know how to make MSCs become bone in culture, but this medicinal activity, this trophic and immunomodulatory activity is the key aspect. So this was the original hypothesis diagram. I screwed up. Where do MSCs come from? I thought they came from stroma. No, they come from pericytes. And if you think pericytes, it'll change the way you think of MSCs. So MSCs, again, not a stem cell. They're not a stem cell. Medicinal signaling cells. So keep calling them MSCs. And of course, relative to this regulatory question, I've been working really hard on this Regrow Act. If people have technical questions, I can answer them for you. But this is my favorite Churchill quote, and I think it's really the end of the beginning when we're all coming out of the dark tunnel and we're going to see the light. Because this whole area of regenerative medicine and stem cells and the new industries that are born, the models, the business models are so different. We've been teaching a business course. This year it's at Harvard Business School. It's in the middle of July. Next year it'll be back in Cleveland. I urge you, if you're interested in the business aspects, the people who are lecturing are sensational with regard to new models for running businesses and interfacing with regulatory activities. All the research in my laboratory has been generously supported by the National Institutes of Health, your tax dollars. And of course, there's a huge number of people at the Skeletal Research Center that I own a huge debt of gratitude for. It's clear I'm the mouthpiece and they're the brains, and thank you very much. Hors d'oeuvres are waiting.
Traditionally, we want to add all kinds of ingredients to our soup, and so based on your presentation, so what triggers in the native environment, okay, replication of the parasites around the vasculature?
Yeah, so we can speculate a lot about what turns a parasite on to do the things I've just described. There's only a few studies, one in my lab and one elsewhere, where we're trying to interrogate the cell in vivo. And that's very hard to do. So the issue is not what kind of tricks can we play on cells in vitro. And all of the immunoregulatory activities of MSCs have been done in vivo. And so what we're trying to do now is by using human cells in mouse models of disease, the human MSCs that we make in my lab from marrow work in models of MS, and models of asthma, and models of bacterial infections. So the human MSCs in these mouse models, we can now interrogate the cell by asking what human proteins get made when, and what's a mind blower is in one of the models, which is a urinary incontinence model, where the urethra is damaged, and by using laser capture, we can tell you that the urethral tissue that is sitting next to a human MSC is making 90 different proteins that it never made before. So the question is, who's making the therapeutic molecules, the MSC or the host? And so my thesis has always been that the MSCs are managers of the body's own innate capabilities of regenerating tissue. And so we're trying to manipulate in old people like you and me to get more MSCs to the site of damage, because we know our own MSCs are not sufficient enough to mount those kinds of regenerative responses. So the answer is stay tuned. We're working on it. We don't know all of the details because we need to do temporal studies.
Dr. Caplan, just to echo with Carlos' question there, when we do the microcapillary damage with a needle, that does further release these parasites from the blood vessels, right? And they become MSCs and things like that.
Yeah, again, mechanical, as I described for lipogens, it's a mechanical technique. And the same, today there was a wonderful demonstration about taking fat and putting it through a very precise orifice, because that's, again, another mechanical technology. But again, I think there's two problems which we're working on also, which is if you look at Mesoblast, the company that actually owns the Osiris technology that I was responsible for, their clinical trials, all of their posted clinical trials, at best, the MSCs, the allogeneic MSCs that they use for therapeutic purposes, at best, it affects 50% of the patients. So 50% of the patients are non-responders. So it turns out that in drugs, pharmaceutical is not well known, that 20 to 30% of the drugs currently approved, patients don't respond to. Of course, the pharmaceutical companies don't want us to know that piece of information. So what's clear is that Mesoblast uses the same batch of MSCs for acute myocardial infarct, for diabetes, for back pain. So those cells are not tuned to the different diseases, nor are they tuned to the patient. And so a 50% non-responder rate, from my standpoint, is fabulous because there's 50% who respond. And I think that's one of the problems with all of our technology and why we want to have a registry. We want to find out what the real numbers are about the response profile from patients. And certainly in the Mesoblast case, we don't know all the details, but we know lots of the details of how the cells are managed and how they're presented to the patient, et cetera, et cetera. So I think what are the techniques which will optimize the release of MSCs naturally? Right. And what are the techniques by which we can augment that population, particularly for people above the age of 5 years of age?
What I'm saying is that when you're putting a needle into a tendon, would it even be optimized if we go periosteally and actually create a little bit of bleeding in that structure versus actually, sometimes we avoid that under ultrasound guidance. Maybe it makes sense to actually get a little bit of extra.
No, it's actually the ortho. You know, I always say the docs do things that they're geniuses. They do things that work, and then 10 years later, guys like me come along and figure out why. So in orthopedics, doing a full hip arthroplasty, 10, 15 years ago, the guys were zapping all of those little bleeders with the electronic cauterizer. Now all of the really good surgeons say, oh, bleeding, that's good. And actually, if you ask an oral surgeon what the most important aspect is of a successful oral surgery is bleeding. And so what's interesting about the bleeding aspect is that that's a call-up for MSCs from all of those broken blood vessels. And so they're there and they're functional. So again, bleeding's bad. Most of us don't like to do that. In a reconstructive sense, bleeding's okay. And actually, I have a whole bunch of so everybody in the room, actually, before we break up, we'll have a test. How many people say, if I, at my age, cut off the tip of my finger, including my joint nail bed, how many say that I could regenerate that fingertip? Raise your hand. There's one lady over there, and four guys and a lady over there who's standing up because she knows the story. So it turns out that the first Caplan rule of fingertip guillotining is don't go to the emergency room because some resident's going to throw a stitch through that to stop the bleeding. And there's actually case studies in England of kids who've guillotined off their fingertips, and they were in rural areas. The mom and dad put a clean towel over it and stopped the bleeding, and so therefore there was a clot. And so when we do experiments in our laboratory with newts who can regenerate their whole arm, any piece of it, we cut off the arm of the newt and we wave it in the air. That's called make a clot. And then we throw it into the filthy pond water. And those guys never get an infection. And the key is MSCs make powerful antibiotic proteins. And so part of management is so all of those antibiotic proteins you're currently making in your mouth, they're called defensins, they're in the genome. When an MSC bumps into a bacteria, it makes this protein. That protein will kill a bacteria on contact, and it calls up a special macrophage to get the carcass out of there so there's no endotoxin effect. So we've evolved this intricate system with these perivascular MSCs, and they're sentinels for defending our body and helping it regenerate. And so my challenge to the physicians in the audience is, so I want you to become MSC biologists and learn how to manage the innate reparative potential of the body. Orthopods have been doing this since Aristotle. You get a bone break, you throw a little extra marrow in there, it helps jazz it up, and it cuts down infection. So again, I think all of my treatise is, as any good physician knows, how do you help the patient do all the things that the patient can do themselves. And what are the mechanisms? And it turns out MSCs are powerful sentinels for damage and vehicles for management. Thank you, guys. Have a good drink.